right, I think we are live. Good afternoon. It's October 22nd, 2021. This is United Medical ACO. My name is Kemal Erkan. I'm here to give you guys updates on COVID cases and COVID-19 vaccination process, as well as we have a couple new topics for this week to discuss. And two of my directors are going to join me today. And I just need to send this link to our distribution group because some of our people are still not following us. So make sure that they have it. Okay, now we are live. I hope I have the right copy link. All right, so now we are going to go ahead and start. Let's see what we have. I'm going to actually just bring the COVID. Okay, so hopefully everyone should be able to hear me okay. I do want to share some of the COVID numbers from the Worldometer source that we always use for these meetings. I'm going to go ahead and share my screen, and let's see, it is right here. Okay, so why this is important for us is we are able to see the daily cases and how this is changing. And many people are looking at these, and then this is a real-time, time-sensitive, real-time data, I guess. So like if you look at what I'm looking at here, so new cases for today, obviously that's not going to be up there yet because it's not done. Today is not done. But then when we go to 2 days ago, then new cases is at 81,000. And then when we look at the day before, which is yesterday, and there's 80,000. So between yesterday and today, there are 80,000, over 80,000 cases, confirmed cases. As you can see, this is actually still happening. Now the problem is because we are in the beginning of the flu season, one of our concern is this is going to actually be a pretty heavy season from COVID and also for the flu altogether. I believe we discussed this in the last couple of meetings where we were talking about the issue of like how we were able to benefit from the flu season last year from the COVID behaviors. So what I mean by that is when the COVID was so fresh in everyone's mind, when we were not used to it so clearly, we did actually make some, we take some precautions. Many people didn't leave their homes. The mask was pretty strict. Everyone was using it. And also we did have the vaccination, because vaccination was not there, socializing was pretty limited. Now this year, my concern is everyone is now used to COVID. Everyone is used to getting these numbers, and not a lot of people are actually following what we are suggesting. And then most people, at least what I can tell, most people are pretty comfortable with what they do day to day in terms of socializing and others. Now, someone who got his booster shot last week, I can tell you vaccination is extremely important and everyone should be able to get it if this is available to you already. So I do want to also kind of give you an update from Delaware to make sure that our Delaware numbers are covered, since we are one of the two private healthcare organizations in Delaware. So our goal for this event is just to really focus on health and community updates from mainly in Delaware, but of course we are part of a bigger organization, bigger region. So from the Delaware standpoint, the percentage of people who are 18 and over who got at least one dose of vaccination is almost 81%, which is a very decent number. It's at least better than the average. And then percent of total population vaccinated with at least one dose is not, like if you take the 18 years and older, if you take that off, that goes down to almost 62%. Now, what we also know is the percentage of test positives, so which is actually going pretty high these days. It's at 7.6. We saw this number almost as low as 1%. That was, if I'm not mistaken, it was in July. And also, when we look at the total new cases, new positive cases, that's about 360 almost daily. And this is a 7-day average. Current hospitalization in Delaware is 186, with 25 of those are critical. That's related to COVID. And for many people who still have questions for the vaccine, I always say that we read these numbers the way that we want to actually, however we want to believe them, or whatever the case we have, that we are trying to make our case stronger. So that when you look at this, many people may say, well, there's like 4,600 breakthrough cases. Well, that's out of 524,000 fully vaccinated people. Percentage-wise, it's 0.89%. So, which we discussed the efficacy of the COVID vaccine, and that's not being 100%. So it's not a surprise for that number to be at that level. So let's see what else we have here. Now, just from the overall country level vaccination process, we have this 75% goal. Sometimes I feel like we are really trying to get to some number that may not be even possible anymore, because every time we present this, it's like 3 months, 4 months away. So we are now 3 months away from 75%. So this has a lot to do with the total vaccination and how many vaccine is being administered every day. And that number is down to 785,000 daily. And that used to be 3.2 million at some point, where we were actually really high on the vaccination when the vaccination first was available. I think we lost our momentum there. So now I'm going to ask our director of our revenue cycle management, our billing department, Richa Savason, to join me. So we try to pick different topics. Here, Richa, we try to pick different topics every week, and some cases we are trying to actually cover certain things for our patients, but there are also certain things that we want our employees to also follow and know. And this is one of those that we want to kind of tell you how our RCM department is working with the clinical integration side, on the clinical side, and what we have in place for United Medical ACO and the workflow and the challenges. Now, Richa's last name is Shah there, but actually it is Savason.
The default.
So I just don't want people to question what I'm presenting, because I said it's Richa Savason.
It's both.
So, all right, Richa, everyone already knows who you are, but if you want to just briefly introduce yourself, and then we can actually start talking.
Sure. Like Kemal said, my name is Richa Shah Savason, so no one gets confused. I am the director of the revenue cycle billing side at United Medical. I've been with the company for almost 11 years now, and we basically manage, all of the claims and the payments that come in for our physicians. And like Kemal said, we also work with all the other departments in our company, and one of the major ones is the clinical integration side. So that's a little bit about me.
Thank you, Richard. The reason I wanted to actually kind of discuss this, it's one of the new stuff that we introduced to our workflow. And I think maybe one of the advantages, one of our strengths is we are adopting new stuff very quickly before many of the other institutions. This doesn't mean that we are always successful with everything, but just trying to adopt new stuff. And as our focus was a lot on the ACO side, as we were learning different parts of the ACO and what we knew, and I'm going to actually maybe discuss some of these with Anthony later on, because he wants to he wanted to talk about the benchmarking, which is our next topic. But what we knew in the beginning versus what we learned in time and what it is now today, the ACO and the metrics and success actually is pretty different than what we see. So it's not the same. Now once we understand a little bit better, we had to make some changes, and I think risk adjustment is one of the biggest part of these types of agreements, and it's in some cases it's so important that one ACO can just make everything about their risk score, and without changing any quality, they can actually have great results, which we have seen those. You may remember a couple of the articles that I wrote in the past, some ACOs who were so bad, but they made so much better returns because they were extremely high on the average expenses. So a little bit improvement from them. They were able to get good results for their ACO. Of course, well, good for them, and this is the agreement, and we are not here to cry about that. But what we want to discuss is, in case our employees are watching this, if you can explain your process of how the RCM is involved with the risk score part of it, and how we are actually using the billing department, the RCM department, who work very closely with the clinical integration part.
Sure. Yeah, absolutely, Kemal. So this, like Kemal said, this is something new that we're trying, that we've recently implemented. What essentially happens is our billing department is in the system looking at a number of claims, right? Whether we need to fix something on the claim or edit something on the claim. So the new process that we've put in place is, while they're in there either looking at the claim or editing it, to take a look at the diagnosis codes that the providers are billing. So some of the important ones that we look for are hypertension, chronic kidney disease. Those are two that are big ones. And then, of course, diabetes. There's an entire list. We have a sheet that we give to our team, and they follow that sheet and they look and see, if the patient has this diagnosis with this diagnosis, what should be billed? What is the appropriate level to bill the patient? Bill on the patient's claim. So what we do is we review it, and if we see any discrepancies or we see anything that is potentially missing, we let the care managers know on the clinical side. So once the care managers are aware of that patient, which is already, these patients are already on their list, so they're already looking at their charts. But if we find something, they're re-reviewing it to see if what we're suggesting is appropriate to bill for that patient, right? And then once they give us the go-ahead and say, yes, this diagnosis is appropriate and what was originally billed is incorrect, we correct it on the billing side and we resubmit it out to the insurance so that they're getting the correct diagnosis information that's pertinent to that patient.
So, Richard, perhaps one of the things that I should have introduced in the beginning is, with the risk score, we discussed this before in different sessions, but in case not everyone is watching all of these. So the understanding these contracts is one thing, but also understanding the billing and coding is another thing. So ICD-10 is the international coding language that we use for the diagnosis. So this is updated in 2016, I believe, right? It was until then it was ICD-9. So we actually, yes, Anthony wants to come in, absolutely. So the ICD-10, what was the main thing for the ICD-10? We wanted to actually identify all the problems to a different level of detail, either more specific or also understand just from the code, we would know if it's the left side or the right side, or just from the diagnosis, extra digits, we would know if this is highest specificity. So with the ICD-10 transition, then at the same time, we were also going through the clinical integration with the ACO contracts. So many companies did not understand how the ICD-10 proper, accurate use of ICD-10 would have impact their outcome and therefore their income from these contract standpoint. So many of them, they learn in a hard way, and many of us, we didn't actually maybe pay enough attention in the beginning. But what I see now is, unless our base ICD-10 specification, so like you mentioned the hypertension. So what we say is that hypertension, everyone is just using as like I-10 as a diagnosis. So, well, every time I say I-10, I smile just because that was my elementary school teacher name was I-10. So, but this I-10 actually is letter I and then number 10. So I-10 is very specific for hypertension, but the issue is from the code, what we need to know is whether or not this hypertension is causing any problems or it's caused by any other problems. And then there are several ones that are attached to it with different illnesses, which comorbidities that we say they may be related to it, they may be originated from it, and if the physicians or providers are not careful, then they may be missing out on the indication of the actual diagnosis, which helps the insurance companies to predict for their future expenses. So why this is important is not just some number, but also insurance is all about the prediction. So what total expense is going to happen is going to be next year. So then because of that, we have to really just do that regardless of these contracts. But then we adopted this with our care managers, with all nurses. But then there was still some missing points where we couldn't review everything. So we involved our RCM, our account receivable reps, who are able to see some of those and flag them for our nurses. And then that way we can actually review them before they go out. Anthony, you wanted to come in for this one? Go ahead.
Yes, because this is very important. You made a point about the impact of this on insurance reimbursements. In our value-based contracts, specifically on the Medicare side, which is the MSSP program, CMS started originally with the approach that it was very important to put in place policies that discourage what is called upcoding, which is the point you made at the beginning of systems that are ACOs or health systems that make shared savings, essentially by coding at a level that is higher than what the actual diagnosis suggests. And in order to eliminate or reduce the impact of this, CMS did put in place some guardrails, but unfortunately, those guardrails have perhaps the unintended impact of negatively impacting some ACOs, especially when you put that side by side with the Medicare Advantage plans. CMS has no such restriction on the MA plans, and those can code significantly more diagnosis. In the case specifically of the MSSP, there is a 3% threshold that CMS places on a 5-year trend for every ACO that's in the system. And on a year-to-year basis, there is a cap that is put in for the ACO. That cap exists in the performance year. But at the same time, the population that CMS compares each ACO's performance to is not subject to that same restriction. So you find a situation where there is an unequal weighting of risk adjustment in a manner that while the ACO's population and risk-adjusted expenditures are subject to this cap, the population that is compared to is not subject to it. So you find that ACOs, even though the CMS never intended it to, ACOs are almost incentivized to push for higher and higher risk scores, even when in some cases the diagnosis does not suggest that. So it's sort of a negative incentive in many ways.
So that's kind of like an important issue. So like, because the same problem, because our Richa and I, we come from the billing. Our core business was always billing. So, and then billing comes with the coding. And then one of the issues that we have seen in the past, well, I've been doing this since May 2000. The CPTs, which level of the codes being the main measure of the payment for the fee-for-service. So then if there's an office visit and physician or provider would charge level 1, level 2, level 3, level 4, the payment would be based on that. And Richa has done so many coding reviews with me in the past where we would actually go back to our providers and say, it's not about how many diagnoses, it's not about how many different things you are putting, but it's about the meaningful documentation. So what physicians should be doing should be telling us exactly what's happening from the HPI, the history of present illness, to the exam, and then to the medical decision making. So there was that fee-for-service did have this problem of maybe creating a culture to do higher. And that was for the CPT is what I'm trying to say. But then when this clinical integration, the ACO value-based contracts focus on the risk score, adjusted risk scores, because actual spend versus the risk-adjusted spend is different numbers. So then the same habit in some cases actually just shifted to the ICD-10 part of it. So just want to make sure that I make this very clear, and then you and I, well, all three of us, we are on the weekly meetings with our providers. What we tell our providers is give us an accurate picture, not high, not low, because you may be setting everything very high, but then if you have a high risk score and if your expense is high, well, it's understandable. But if you have a high risk score and if your expense, actual spend is low, that means maybe you are actually misleading in a way. So because, Anthony, what I have seen is the logic of all this has to work in a really good circle. Like it has to work in a really good way. What I mean by that is, so if the risk is high, your expense is gonna be high, so understandable. But if the risk is low and if the expense is high, which in many cases we see this, that means either we are not capturing the risk of these ICD-10s in a proper level, or the patients are just spending way too much on unnecessary tests and other stuff. But mainly it is because we are not capturing them accurately. So we don't want any of our providers to do anything different than exactly what it is, because I want to know if it's a hypertension, if the hypertension has kidney problems, this patient has chronic kidney problems that's related to the hypertension, or if they have chronic hypertension and they have heart disease related to the hypertension, because that's an important, if I'm the insurance company, that's an important indication for me to update my prediction for that expense for that patient next year. Right?
Yes, and plus the fact that it's significant, it also reflects the level of care which the provider is then providing for that member, recognizing that this is a higher risk member requiring greater care. And it is, you're correct in this when you say that it's all supposed to tie in the sense that the enhancement in the care of the patient and the recognition of the higher level of care of that member to reflect the level of risk of the member is in turn rewarded through the reimbursement system and through the subsequent prediction in the expected level of care and cost of that member in the preceding year. So this is how it all ties in. But in the sense that in order to control the negative impact of upcoding, the CMS brings in policies that at the same time begins to constrain the ability of these providers to reflect that level of need, that level of care that the patient requires, and therefore the level of reimbursement, the total spend attached to such a patient. When there's a disconnect between that you see that the linkage that we speak about gets, that disconnect now comes into play there. So that's one of the critical issues that that's being raised towards the CMS in terms of some of the policy changes that's required as we move into next year and the new physician fee schedule, for instance.
You know, when maybe part of the reason we have to kind of discuss at this level is because the way that, like why we brought the billing side into the clinical integration and the risk adjustment, although it's not clinical from their side, is because now one of my main points of changing the behavior of the population was one thing, but also changing our providers' behavior to capture these. It was another challenge. So then even if we review these charts, and even if we make these corrections, then what we have seen is providers are not following some of those at the same level. So like we make the chart level adjustments and we update the problem list, but then the patient comes back again, and the next time, if they are not using the updated diagnosis, then the risk goes down again. So then the billing side is extremely important from that point to kind of just flag these types of kind of like suspected diagnosis. And I-10 actually is probably one of them, one of the strong ones, and the other one is like very much under coded is, or not specific to coded is at the highest specificity is the depression. So then depression being unspecified, then it just doesn't give you any risk score, versus if you are saying that this is a recurrent mild depression, you actually get a risk score. So we flag those, and then I think our RCM side is actually doing a really good job to flag some of those, because when I do the daily case conferences with the nurses, I see a number of patients are being assigned to the nurse to do the reviews. So that was one of our maybe approaches that we have done. Now, Richard, you guys have done a lot of also corrected claims.
Correct.
As part of the outcome.
So it's a cycle, right? The care managers send us the claims that they found that need corrections. And now we're basically closing that cycle by also looking on our own to see what could be updated and sending it back to them. And then when they review it, it comes back to us as a corrected claim. So we go in, we correct the diagnosis codes, and then we resubmit the claim with the new diagnosis codes.
Yeah. All right. Well, Richard, thank you for joining us for today, and I will continue with Anthony because we have another topic. But you are welcome to stay if you want.
Thank you, Kemal. I'll be on listening.
Thank you. So, Anthony, we wanted to discuss the benchmarking issues, and I think maybe with this revenue cycle management side, we kind of got into that earlier because they are kind of connected.
Yes, because they're related. This week, I don't know if you're aware of it, but this week CMS did release its long-awaited new strategy for health system transformation. I think it looks like you're frozen. Am I correct?
So right now, I don't know. So I think.
Okay. Anyway, yeah, it seems, yeah, that's better now. Okay. Moving on. I was saying that this week, CMS released it's a long-awaited health new strategy for health system transformation in the next decade, and part of it is that it expects that all traditional Medicare beneficiaries will be treated by a provider in a value-based care model by 2030, which is 9 years from now. And it anticipates achieving this milestone through 5 main strategies, including accountable care model, which we are a part of and which we had been discussing in the last segment. And it typically evaluates ACOs on the basis of cost, on the basis of quality, on the basis of patient satisfaction, but he also wants to add a fourth approach, which is evaluating ACOs on the basis of equity, health equity. Now, at the same time, there was a lot that was expected from these strategic changes. One of them is issue of benchmarks, and we touched on that a little bit in our last segment. And in the next slide, we show that typically, Kemal, we joined the MSSP ACO in 2016. Our benchmark to set our historic benchmark, which is the expenditure level on which our performance is constantly judged, right? CMS does a 3-year look back. So it was looking at our expenditures in 2013, in 2014, and 2015.
Mm-hmm.
Now, fast forward to our next renewal in 2019, then CMS did a 3-year look back from 2019, right? Which meant that we were being looked at in terms of our performance in 2016, 17, and 18,
mm-hmm.
right? Now, it also did make a significant change at that point in time, at the point of our second renewal in 2019. It changed the benchmarking process to now include comparison, not just to our own numbers, which is those prior 3 years, but it also compares you to the region in which you belong. So for us, it will be Delaware and the neighboring states. That's what essentially represents our region within CMS's calculation. Now, what that effectively meant was that because our numbers, our performance year expenditure, for instance, in 2021, is put into the mix in the calculation of the regional expenditure. Now, what that means is that if we reduce our expenditure at the end of 2021, this move has the effect of reducing the overall regional expenditure because our numbers are part of this calculation. Mm-hmm. Our numbers have our reduced expenditure has the effect of reducing the regional expenditure level. Now, on the other side of it, a similar ACO within our region, let's say that ACO increases, doesn't perform well, increases its cost. What that ACO has done in effect is increase the regional expenditure level. In other words, it gives itself a greater allowance budget-wise, even with poor performance, to be able to gain shared savings, because the regional benchmark, its own benchmark is increasing vis-a-vis the regional benchmark. Whereas an ACO such as ours, which at the end of the year reduced expenditure, ends up reducing regional expenditure. And this is what is referred to as the rural glitch, because it has a greater impact within the rural areas. And if that ACO that had increased expenditure, for instance, commands a greater market share within that region in place, it will, sorry, the light's gone up here.
You have to move every once in a while.
Yeah, it's a strategic error in the mechanisms in play on a year-to-year basis within the MSSP program, because it has the effect of rewarding poor performance, because those ACOs, especially if the ACO has a greater market share within its region, that ACO has the ability to negatively impact a neighboring ACO. So technically speaking, we will say that ACOs do not necessarily compete with one another, because you're being assessed against your own performance, against your own historical benchmark. But as long as your numbers are part of the regional calculation, it effectively means that ACOs are competing against one another. And the larger ACOs with larger market share has the ability of negatively skewing the expenditure level, the benchmark within each region. And that's a big problem. That's a big problem, especially for smaller ACOs.
So let's put this in perspective so that people understand why we would be bothered by this, right? So in Delaware, we are one of the 2 private ACOs, and then there are 2 hospital-based ACOs. One of them is the
3 hospital-based.
Well,
3 hospital-based, yeah.
There are 3 now. Well, the other one is that the ESRD-based one, or?
You have the St. Francis, which is independent of Christiana, BB, and Bay Health, which are part of eBright.
Yes. So then.
So you have the 3 hospital groups in one ACO. And then St. Francis, which is incidentally, St. Francis is part of is moving to become part of Trinity.
They were with Medical Society
yeah.
for a while, yeah. Now, the thing is, why this is important for us is we have, from the Medicare standpoint, we have about 11,000 patients in Delaware. Now, with the Medicare Advantage plans like Humana, United Health, Dual Plan, now Highmark coming into the market, some of those numbers are going to go to Medicare Advantage plans.
Yes.
And then you have the hospital system that already put 4 hospitals actually, Christiana, Bay Health, BBN. I think Nancoke is part of them, if I'm not mistaken. Maybe with Tidal Health, they separated.
Yes. Yes.
Before Nancoke.
Before they were part of.
Nancoke was kind of like the satellite to Christiana. I used to call them the Christiana Hospital's helicopter would be just sitting there for patient transfers. So, but I think that changed now. Now the problem with this is now with the regional numbers being important, the regional benchmark being important, where if you are not part of that, if you are smaller in that percentage, in that mix, then the things that the bigger ACO or the bigger hospital system can do may impact the outcome of the smaller ACOs like us in this case. So, well, we dealt with a lot of unfair stuff in the past, so we'll deal with this one too.
Yeah. So, the other part of this is that because of a lot of advocacy, a lot of people, such as in forums like this, speaking out about it. CMS is well aware of these two issues, the benchmarking issue and the HCC risk adjustment issue that we spoke about earlier. But unfortunately, it's looking to address this outside of within the rulemaking process rather than following the annual physician fee schedule reviews that it typically sets out at the end of every year. So it was expected that it would become part of the 2022 physician fee schedule review process, but it's not so far. And it's one of the things that the national body of ACOs is pushing very strongly against.
So, Anthony, I think the challenge that we always have, is dealing with one is unknown, dealing with the unknown. Now, we are private groups, and we were in this in a way that we Medicare said they're going to do MSSP, we apply for it, but we didn't know what was the rules of the MSSP, what it was going to be in the beginning. Like, we started in 2016, but some of these rules already made up in the earlier part of 2010s.
Yes.
Now, and this part, if I know sometimes you don't like the confrontation with these things. It's just my personal opinion. Even for the private ACOs, when you look at one of the big private ACO, and when you look at their background in terms of where they worked before, like, I didn't have any work with CMS or the government before the MSSPs. You did not any direct contact with these people. John Donnelly did not. Donna Gunkel did not. But when I look at one of the big, I'm not going to, you can relax, I'm not going to mention the name of the ACO, but the other private ACO in Delaware is their higher ups, like their leadership team is all the people who worked with the government before. So I can help but think about them knowing some of these stuff, not what's happening today, but what was set up in the beginning. Because when we discussed the ICD-10 transition in 2016, what was one of the biggest problems? Maybe that was the wrong year for us to go live. Perhaps we should have done it a year before or a year after. Once we start using it. Now they may have known this ahead of time.
It's possible, because you can't understate the value of experience in this, because it's that experience that enables you to make strategic decisions ahead of time. And a lot of this is about timing. And decisions on timing are based on, in many cases, information, based on the experience you drawn from access to the information. And so in that regard, as we've spoken about before, when you look back 3 years from our starting year, which was 2016, the historical benchmark for 2013 was relatively competitive within the market. In 2014, it was similarly competitive in terms of the market. And then for 2015, for reasons that we were never really able to properly establish, our benchmark was drastically lower vis-a-vis the market, and the process of historical benchmark determination weighs heavily on the third year vis-a-vis the first 2 years. So the impact of the benchmark in 2015 15 is at 60%, I believe, and the other two at 20% each. So rather than begin from a starting point, it's like being in a relay, and you're starting from the 100 meters starting point, and someone else is at 200 meters, and you're doing a 400, you're doing a relay. You're never going to be able to catch up, right? Because you're starting much lower down the line than someone whose starting point is at the 200 meter mark. So this is where the experience, the knowledge, the access to information, and the experience comes in order to make that strategic decision in terms of the timing of entry and so on and so forth. But having said that, each ACO, and some of the studies have shown that, some of the reviews of the ACOs over the last decade have shown that each ACO typically goes through, each new ACO typically goes through a 2-year period, 2-3-year period, during which it typically will post poor results. But as systems consolidate, right?
The ACO is about 3 years. I think, Anthony, you're cut off. I don't know if I'm not able to hear you or. Go ahead. No, we can. I cannot. I mean, I hear you from the other room, but I cannot hear you from my. I think there's some disconnect there. No. Rich, are you able to hear him?
No, Kemal, I'm not.
Okay, hold on. Let me get him. Well, you want to just come in here? Right, so I invited Anthony. He's in my conference room, so he's right here, so we can actually finish together here.
So I was saying, you cannot overstate the value of the experience that groups such as this, having come especially from the government and the CMS system itself.
But if I worked as the advisor to President Obama for healthcare, I would have known some of these stuff before I started my ACO.
Of course,
right?
Because you know, you have the experience to be able to tell when is the best time to start.
Exactly.
Right. When is it that your takeoff is from the 200 meter mark, as opposed to starting from the 100 meter mark in a relay with several other people. So that's where that comes into play. And,
exactly. So now, Anthony, now because we are right next to me, so I don't know, I forgot how to address you now. So, Richard, if you are still there, you can join us. But now we are going to close the session. But one of the things that I was going to tell you, what I mentioned to you last night, right now I'm in the middle of getting the comparison of the hospital expenses per admission between last year versus this year with a couple of the insurances. And while we are talking about regional benchmarks on MSSP, we also need to kind of look at it as what's in our control versus what's not. So our 78% of the expenses, about 78, is spent for non-professional fees, such as facility, labs, and others, which is not part of the physician reimbursement. So I do want to actually bring that up if it's going to be ready for next week, if it's not following week, just so that people can actually have a good idea what we deal with on a day-to-day basis, because we are working with these metrics given to benchmarks that's not in our control, because patients come in and go in some cases. So it's a difficult challenge, but we're not complaining necessarily, but we are just having a dialogue, so then it can help if we need to give some feedback to the CMS people which they are looking for those. Hopefully we can actually make a good point, and maybe now we have more experience, now we have more contracts under the ACO, we can actually guide the market in a proper way, because we know that there are a lot of issues that's not working the best interest of the patient and the private practices. So hopefully we can do better. Now, did you get your booster shot?
Not yet.
I got mine, so do it on a Friday. I hope Anne is not listening this, but it did not meet out for 2 full days minimum. So they said that as you are younger, your body reacts better. So that means I'm young, right? So now, Richa, you definitely need to get it soon. So you should be able to get yours maybe this week or next week.
Yeah.
I'm doing mine on Tuesday, Kemal. I'm actually scheduled.
So how did you do?
I'm doing it on Tuesday.
On Tuesday, I'm sorry. I thought you did on Tuesday. Okay. Well, Tuesday, so we can probably then call you out for Wednesday and Thursday from today.
I'll be fine. My vaccine reaction is.
It hit me actually a little bit harder than the first 2, but
Yeah.
Obviously we have to do it, and I did it, and I'm hoping that everyone can also do it once it's available to you. You should be doing it. So that's our final comment for today. Thank you for joining us, Anthony, Richa. Thank you for being with us. Well, today is kind of like the new era for us, because Tanner used to help me with this. So it was last week was his last day. So we have someone who's gonna replace what Tanner used to do for us. But I always have different guests for these sessions, and Richa and Anthony were available, and I hope this was a good discussion for everyone. Thank you so much. Have a nice weekend, and I will be live again in 4 minutes. So I'll see you guys soon. Bye-bye.